in, and then we lose track of the patients. They go out, and then they don't come back to have them removed in a timely fashion. And the longer you wait, the more difficult it is. There's 98% success rate at 3 months, drops to about 90% at 6 months, drops to about 80% at 1 year as it becomes endothelialized. And so if you're going to put these things in and you're planning on getting them, you really need to document that you've had that discussion with the patient, and you need to really do everything you can to get that patient in. I think we're getting better at this. At the University of Colorado, we actually have someone who's one of our nurse practitioners' job is to keep an eye on when these filters come in and track the patient down and bring them back to have them retrieved. But sometimes you still can't go get them, and so this again raises the issue, because if they're not decreasing the incidence of PE, these are retrievable ones, and we leave them in and they have the potential for harm, well, you can see the obvious problem there. And our friends in the law world have figured this out, right? So this is the late night TV. Do you have one of these filters? Come talk to us about this. So I think it is an area that we need to be cognizant of, and certainly need to be paying attention to as we put them in when we think we should put them in. And there are scenarios where I do put them in, though I have to. It is it's becoming less and less clear how to use these. Call anytime. Free case review. Antithrombotic therapy, ACSP guidelines do not use IVC filters if you can anticoagulate. These are the recommendations. Use IVC filters if unable to anticoagulate. Conventional course of anticoagulation if the filter is placed. This gets at they're not recommending necessarily prolonged anticoagulation, even though the DVT risk is there. So I'd say I don't totally agree with that recommendation myself. If I do have a permanent filter in, then I continue anticoagulation to avoid the DVT. So last thing, I've got a few more minutes, so I want to save some time for questions. So going back to this, this window of the soul, the RV and PE. So what are our options in terms of the acute management of the patient who is really spiraling down, this acute heart syndrome, if you will? And this, again, back to the land of the blind, we're really entering, again, a no data zone at this point, but I think it's an interesting area, and that's the use of mechanical support in the face of a failing RV. And mechanical support, that is percutaneously placed mechanical support, can be drawn into two different areas. That is direct RV bypass versus indirect RV bypass. So direct RV bypass, meaning you're going, removing blood from the RA, delivering blood to the PA, so directly passing the right ventricle, if you will. And our options for that percutaneously are the Impella RP, the Tandem RVAD, and then the Protect Duo, which is sort of the newer iteration of the Tandem RVAD. And then indirect RV bypass is essentially ECMO. Removing blood from RA or IVC and then delivering blood into the arterial side. And is there any use for these in the acute management of acute RV failure, in particular in PE? There certainly is indication in acute RV failure for other reasons. Would it work in a PE? So this is an example of the Impella RP. So this is placed femorally. So this is a 23 French pump, circumferential with 11 French catheter. Again, drawing blood from the IVC-RA, delivering blood into the PA. There we see it on image from that standpoint. This is the Protect Duo. This one can actually be placed via the IJ, so you can get the patient up and move them around if needed. Again, drawing from the RA, delivering to the PA. This pump is external as opposed to the internal pump in the Impella RP. And an important concept whenever you're using these is the idea of the HQ curve, H being the pressure head, Q being flow. And so essentially all this is showing is that if your pressure head that is the pressure differential from RA to PA is high, then the flow will be limited, because flow now becomes very dependent essentially against that pressure head and the essentially rotations of your pump. So in the face of a big PE, if that pressure is high, your flow can drop off significantly. If, for example, the reason your RV's failed is an RV infarct, then because your pressure head is essentially low, they tend to work pretty well. And so this becomes the question, can we use these mechanical devices in PE? And I don't have an answer for you. This is something we're playing around with a little bit at the university or at CU, but I'm not sure these are going to be our go-to in this situation. They call for it, you need to activate the cath lab, et cetera. And it's an acute scenario where you use it. I mean, it can be done, but maybe I think that which we're perhaps more common or used to in this room, the use of ECMO may be a better option, at least at this point. And so use of ECMO tends to be VA ECMO. So again, we're talking, again, really severe cases of RV collapse here at this point from PE. VA ECMO, again, now drawing venous, delivering arterial, so supports blood pressure, can also can oxygenate. Is there data on this? This is, again, this is sort of hot off the press, 2018. This is the utilization of veno-arterial ECMO for massive pulmonary embolism. This was done actually down the road here in Maryland, University of Maryland. This is, I would not say fantastic data, but I just think it's sort of an interesting idea. So this was a retrospective review of what they called an aggressive protocolized ECMO for massive PE. And I will emphasize that this was aggressive. And so what they looked at was their data over about 4 years. They found 20 patients where they had used this aggressive protocolized approach. So these were patients who had a massive PE, hemodynamic collapse. ECMO was opted for. They say in their entry criteria that all patients were considered unless they were deemed to have a less than 1 year survival, which is kind of funny in the face of massive PE, because that may be the case. But some of these patients were undergoing CPR when it was placed. Many of them were sort of in extremis. 20 patients, and essentially they placed them on VA ECMO. They then assessed them from a neurologic standpoint, from a perfusion standpoint, organ-wise, and from the standpoint of RV function. They looked at TTE and CTA at 3 days. They did not lyse. This was just now anticoagulation. If there was evidence of RV failure, they actually took them to embolectomy. So at that point, so went to surgery for embolectomy. If the RV looked okay, they decannulated. And what they ended up presenting was survival in hospital in 90-day of 95%, which was significantly higher than one might anticipate for this group. Now, all sorts of issues with this, right? There's selection bias, and this is going to be huge. This is a retrospective look. You have 20 patients that were, deemed to look okay. But the main reason I mention it is that this, I think, becomes an option if you have a place that's interested in ECMO, an ECMO team, and can put this in place. It can be done at the bedside. It can be done percutaneously, and really gives you this sort of very invasive treatment when deemed. Now the trick becomes who to use it on, because you end up in ECMO in the wrong patient, you can really get yourself into a world of hurt in a hurry. So an interesting area, controversial, almost no data, but I think it's an area potentially evolving here at this point. So in summary, filling this up, so PE is prevalent and has significant mortality. Lytics, high risk or massive, really no argument. Intermediate risk, and catheter directed, it becomes questionable how we do this. IVC filters, I have to say their use is becoming much less clear in this time, but still there are some new filters coming down the pipeline that may be of interest. I didn't dig into those here today, but perhaps. And then RV support, this is definitely a very new area, new directions at this point, and how we use this is not entirely clear at this time. So controversies in the management of PE. With that, I will stop and thank you for your attention and take any questions. And that's my daughter trying to decide if she wants to go down that hill or not, right there. So.
Excellent talk. That was terrific. Are you aware of any studies? I guess I would preface this by saying that a bunch of us sit on a PERT team, and so we get these calls trying to suss out what to do with these patients who are intermediate or sort of high intermediate. We're trying to figure out, do we give thrombolytics to this person who's not obviously a candidate? So and we sometimes kick around the possibility, well, the catheter directed, they're using smaller amounts of lytics. Is that a little bit less risky? And so I guess my question is, could we do a fair assessment of, say, 20 milligrams of TPA systemically, which is a sort of similar amount to what they're doing through the catheter-directed lytics? I've never seen that study. I don't know, is there anything like that?
Yeah, so I think it's a great, and that's actually where we've written that protocol and are actually starting to look at that right now, because I think, to me, that is sort of the obvious question here at this point. So why, if sticking a catheter, if that thrombolytic is not sitting by the clot anyway, if it can be administered systemically via a good port IV, which we do all the time, why not just kind of use a catheter-directed approach to this? So give 20 milligrams over, prolong your period of time. And part of my, the way we're getting this through our IRB is that there actually is literature looking at this, well, it's case series, I wouldn't say literature, but a pretty large case series looking at this at thrombosis in mechanical valves on the left side of the heart, where that same protocol is used when there's a thrombus involved, either a mechanical, mitral, or aortic. And in fact, I've done this in a couple of our patients as well, where we've seen this, and it will break that clot up on that left-sided valve relatively effectively. At least that's been my anecdotal experience, and that's what the series shows. And with a complication risk that was actually pretty low, lower than one might think for trying to lyse the clots banging around on a left-sided heart valve here at this point. So yeah, I think we're exactly interested in that. I kind of think again that sort of makes sense to go down that road. So
Thank you.
Are you aware of any data that suggests if someone has a calf DVT in the hospital sick with other comorbidities and absolutely cannot be anticoagulated, would you put a filter in that patient, or are you aware of data that suggests a filter is not indicated?
So you're talking about below the knee DVT,
Correct.
which is already a controversial area in terms of anticoagulation that as well. So am I aware of data on it? Other than the only not, and I've searched, and actually I was very pleased when I finally found that University of Cincinnati study. The only data that's ever looked at this again for filters, and those were not our temporary retrieval. Those were, essentially cut down filters. That was the Mobanudin filter that was put in, showing that you will decrease your incidence of recurrence if you can't anticoagulate. So people, I think this is, ends up being a 2B recommendation, meaning lack of evidence, but people agree that it's appropriate consensus of experts to place a filter for clot you can't. Now below the knee becomes again a whole other area of controversy at this juncture, right? So part of the recommendation might be repeat ultrasound to see if you have extension at this juncture as opposed to anticoagulate. Because I see both the PEs and then the CTEPH patients, I have a lower threshold for anticoagulate. So even in that scenario, I do tend to anticoagulate, though it's or would I drop a filter in that? That gets a little bit harder because I probably would, but I think you could also make an argument that you could follow with ultrasounds in that scenario. So
Okay, thank you.
yeah.
Just referring back to what you discussed, placing IVC filter in patients with residual DVT after PE. I was just wondering, did anybody ever break down the data? I mean, you can be very inclusive and say, as Dr. Vahid pointed out, patients below the knee clot versus people who have a thing dangling off their iliofemoral veins. Did they break down that data? Because I think we all sort of intuitively know what patients we're really worried about when we do that. I just was wondering if they broke down that data.
Yeah, so there actually is. So that iliofemoral free-floating DVT is actually mentioned in some of these subgroup analyses. Though interestingly, the ones that didn't actually show an increased incidence of even embolization in that scenario filter versus. So it wasn't that still becomes not like an absolute indication for filter. It really is kind of the difficult area of filters that we don't have great data if you can anticoagulate them to show that they're going to benefit from it. But I set that out there, but if we go to PREPIC 2, because PREPIC 1, well, I say that PREPIC 1 did show that you dropped the incidence, right, 1% versus 4%. I always kind of hung my hat on that. PREPIC 2 did not, though they didn't really look in that short run. They looked at 3 months, but presumably they would have picked up PEs, in that period of time. But not interestingly, PREPIC 2 was high risk, but it wasn't necessarily the patients that we would be really worried about. Like it wasn't the patient or the one that I worry about the most, where the RV is blown out. Even another little clot could be a fatal scenario, which is where I kind of hang my hat on PREPIC 1 and say, I'm going to drop my incidence 4 to 1%. I'm going to take the risk, and I'm going to go back and get that filter, and we'll risk it. But PREPIC 2, only a small subset actually had that sort of RV dysfunction. Most of it was age. It was comorbidities, that is cancer. It was history of stroke. It was things like that would increase the risk of recurrence. And the other funny thing about PREPIC 2, which is there's all sorts of ways to kind of pick that apart. I mean, our interventional radiologists go, oh, they used a defective filter. They used the ALN. We never used the ALN. That's why it didn't work. So that was their argument. I don't know about that, but the incidence of it, they had by PREPIC 1 assumed that they would get about a 5% incidence of recurrent PE. They only saw 1.5%, so they weren't powered then effectively to see it at 200 patients, and so that becomes an issue. It was just not a big enough study to show the difference. So.
In the proximal, lack of any sort of significant difference using the ultrasound feature of the ECOS catheter in proximal DVT. What role do we see it playing in PE? I mean, it's routinely used in this hospital. and presumably is more expensive.
Yeah, yeah.
sort
So it
of
makes a lot of money.
protocol.
So there's a positive there at this point. No, I mean it's. I mean this is the problem with devices, right? They get approved and they go, well, it costs more, must be better. At this point, but it was approved without a study showing efficacy, and then this was most. So I don't, that honestly, I mean, that's what we have. I mean, we do have pigtails, we put them in, but we have Ecos, and we're doing this thing. We're putting them in, and every time I put them in, I'm like,